Hey, this is Carol Higgins, and I'm giving you a brief run-through on Paragon, which is the charting system in the charting program in the McLaren system. You will be having your CTA co-sign your charting, so you don't have to know this inside and out. This is just a brief exposure to it, so you at least know what some of the buttons look like. So you will get to this Care Glance screen and you will get sign-ons and passwords at the beginning of the semesters. You will get to Care Glance, and your CTA will help you do that. And then what you're going to do is click on Care Glance, and it's going to bring up patient roster. This happens to be for the ICU. What we're going to go through at this point in time is a med-surg unit, which is an oncology unit. Once you click on what unit you want, you go over here to retrieve, and it will retrieve the patient info for that unit. So we are going to click on this patient, and when you highlight the patient, you now have access to these buttons. In addition, the main part of charting that you're going to use is this charting form looking thing here that you click on, and you will click on daily assessment. You can go in and chart 12 times a day under daily assessment. You'll do your initial assessment for the shift, and then you go in, and every time you chart, you're going to chart on daily assessment. So you click on daily assessment, and now it says, okay, do you want to use this date and this time that you're charting? Well, let's say you made rounds in the morning and you got people with their breakfast and you passed some meds, and now it's 9 a.m. and you got 4 assessments to chart. Well, you did them about 7:45, 8:15. So you're going to change this time by just scrolling over this and saying, oh, 7:45. So now it says, I am charting the information from today at 7:45 in the morning, and I say okay. So this screen is a bypass screen. All you're going to do is click OK, and it goes away. So now this is your chart form, all of these buttons. You don't have to chart on every button. What you do, like doing a focused assessment, is you're going to choose those things you're going to address. So the first one I usually go to always is safety and hygiene, because every time we enter a room and interact with the patient, we make sure that their side rails are up as a safety, their call light is within reach. We tell them, call us if you need us, and the bed is positioned low with the wheels locked. And that is pretty much what we do every time we interact with the patient. We also check their ID band oftentimes. And now we can talk about if we gave them a bath or they took their own bath, if we reposition them to the left side, the right side, if we got them up in a chair, if we did help them with oral care or did their oral care, if we got them up to a commode, or if they're on bed rest, was it with assistance, without assistance, if they're on a specialty bed, if they're in isolation, if we did catheter care for a Foley catheter, indwelling catheter, what kind of precautions they're on. And then we do use the rounding button frequently to talk about, okay, I just dropped in, checked on my patient, and I talked about pain. Do they have any pain, or is their pain better? Or I positioned them, or I offered toileting, knowing that these things oftentimes help us meet the needs of the patients without them having to put a call light on. So this screen I use frequently. I want to talk just a bit about this precautions. So everybody's on standard precautions, but we have aspiration precautions. So you need to think, who would be on aspiration precautions? I'll give you the answer. It's a stroke patient. Any stroke patient is on a swallow valve every time we interact with them. So they are on aspiration precautions. Chemo precautions. So somebody on 11 South, which is the oncology, med-surg oncology floor here at McLaren, may be on chemo precautions, and what that means. In addition to that, they may be in protective isolation if they're on chemo precautions. If they have DTs and they are actively withdrawing from alcohol or sometimes other drugs, we would put them on DT precautions, which are padding the side rails and frequent rounding, etc. Seizure precautions, again, padding the side rails. Suicide precautions, radiation precautions. So think about who would be getting radiation that you may have to keep them in some kind of a special protective environment, protecting you or protecting them. So we think about people with thyroid ablations where they're using I-131, which is a radium that's injected. They are on radiation precautions for anywhere from 3 to 5 days. And all of their body fluids are handled differently than normal biohazard disposal. C-spines precautions. So this is anybody who's had a fall where we are concerned about the integrity of the cervical spine. Fall precautions, many patients are on fall precautions in the hospital. We know it is a quality endeavor to keep people from falling. There are programs, and you will go through with your CTA what all of the pieces of that is, with slippers and warning signs outside the doors and on the charts and frequent rounding, etc., to prevent falls. So not uncommon to have a patient on, many patients that you're caring for on fall precautions. Bleeding precautions. So this is any patient on an active anticoagulant such as therapeutic heparin, Coumadin, Eliquis, any of the 10A inhibitors. You would use bleeding precautions. In addition to that, you may just put a patient on bleeding precautions for 24 hours if they've had a thrombolytic like TPA for stroke or TPA for MI, which we don't use here at McLaren often because we have interventional cardiology, but they may have come to us from Marlette Hospital that does not have a cath lab. And they got TPA up there for an acute MI. We get them 6 hours later by ambulance, and they are still on bleeding precautions for up to 24 hours because of the nature of the drug. So you can click what kind of precautions that the patient's on, and then you need to make sure what those precautions include so that you can appropriately care for the patient. In addition to that, from the oral care point of view, we do have for non-vent dependent patients, so this is not where patients are intubated and we're trying to prevent ventilator-associated pneumonia, but rather, quote, normal or routine oral care. Different things that we may use. If they have dentures, we put them in so they can eat well. That's obviously something that needs to be attended to, and you may not be charting that. The nurse aide may be charting it if they're the ones setting the patient up for their meal. So again, these are not mandatory, but I frequently use this screen. The next one is pain. If your patient has 0 out of 10 pain, you click it and you're done. You go on to the next screen. But if you're going to do a pain assessment because their pain is greater than 0, now you get a screen that says, okay, I'm going to click a locate or chart a new location. So I get the screen for location here, and I can click abdomen and say, okay. And now I have abdomen here, and I can say, this is what I want to chart on. Okay. Life is not responding. Okay, thank you. We're going to close that. So we're going to do pain assessment, come to abdomen. I'm trying to get back to that screen I was on. No. I don't know why it won't let me go to that. Well, that wasn't helpful. Okay, we're going to come back to pain because it's not letting me go there. If you click on the sepsis screen button, it is mandatory that you complete the entire screen before you can go to another button. So if you have no intentions on doing the sepsis screen, which we do frequently on patients, don't click the button. So I'm going to move on to DVT because typically we want to identify those patients who are high risk for DVT, knowing that the majority of our patients in the hospital are at least moderate risk, if not high risk. And then we're going to click on some of the interventions or prevention stuff that we do. So let's say our patient is 59. They have congestive heart failure and swollen legs. So that gives us a 3, and that puts the patient in moderate risk. And typically, we would use intermittent compression devices for both legs, or we may have them on compression hose, whether it be Jobst or just regular compression hose. So you can click this, or you can say no mechanical prophylaxis. Why? Because of a medical contraindication, and that contraindication is these swollen legs, and we don't want to break down skin. So we identify those patients and what their risk factors are, and we then identify their category, and we can then talk a little bit about what prevention interventions we use. In addition to mechanical, we frequently use at least low-dose heparin. 5,000 sub-Q, Q12 hours is a common dose. Let's go to the neuro screen. Now this is general neuro. We are not looking at the critical care screen at this point. This is just general neuro. So you go in, you're evaluating your patient, and you say, oh, they're a little drowsy, but they respond to verbal stimuli, and they're oriented to person and place, but they are not oriented to time, but they are oriented to situation. So you've got a patient who's a little drowsy. Maybe it's 7:30 in the morning, you just woke them up. Say you got some meds for them and you give them those meds with some water and they swallow without difficulty. They have no speech problem when they do wake up, and no signs and symptoms, headache, facial droop, etc. If you check their pupils, you can document if they're brisk, sluggish, or whatever, the size. You can also document arm strength bilaterally, grips, and leg strength. So we get a pretty good neuro picture from this screen. If you were going to document Glasgow coma, which actually is reflected over here in these buttons, you could say they open their eyes to speech, they are relatively oriented, and they obey commands, so they get a 14 out of 15. So that's your general neuro screen. Unless something's changed, you don't need to go back every time you enter this chart to chart neuro. But typically on a 12-hour shift, we're going to chart twice, maybe 3 times on neuro, depending on what's wrong with the patient. Ear, nose, and throat. Here you have the ability to chart on vision, so eyes and ears, nasal and sinus if there's drainage, throat, tongue, mucosa, gums, etc. Again, we do not do a full ear, eye, nose, and throat eval on every patient. But there are some patients where we want to specifically talk about what we observe and assess. So say the patient has significant scleral edema or periorbital edema. So this could be your patient who has facial trauma or who had a big facial surgery, an elective surgery. Or say you have drainage from the ears, and you know that the patient had a basilar skull fracture, and you know that drainage from the ears, clear or bloody, can be a sign of a disruption of their cerebrospinal fluid from this basilar skull fracture. So this would be an appropriate place to chart drainage. Otherwise, you can just say normal if in fact you want to comment on it. But typically, again, we do not do a thorough ear, nose, and throat assessment on patients with an otoscope and all that stuff. If they have no symptoms, you can chart normal. Oftentimes, I do chart their oral mucosa, especially for patients that are mouth breathers, and I want to say, oh, this dry mouth is an issue. They have a cracked tongue, they've got caking on their lips, etc. So sometimes I do chart specifically on tongue and oral mucosa for somebody where it's a problem. Cardiovascular, again, this is not in critical care. This is our basic cardiovascular charting on a med-surg tele floor. So what their heart sounds like. So do you hear S1, S2? Is it strong? Distance? Do you hear rub? What their pulses are like, anywhere from palpable to absent, including Doppler, if you have to get a Doppler to assess their pulses. And you have both radials, dorsalis pedis, posterior tibial areas to chart. What their capillary refill is, if they have any JVD, is it present or absent? And then if they have any edema, what it looks like, and if it's pitting, then how much. Where the edema is, and if you're on a telefloor, you would chart telemetry, and you get a box number here that you would put in, and you can, with your CTA, who is arrhythmia competent on a telefloor, identify the rhythm. As a student, you would not be responsible for identifying the rhythm, although many of you may feel like you are well-versed in what rhythms are, and you can discuss your patient's heart rhythm with your CTA and then chart accordingly. If the patient is on, let's say, 12 tower, and they have had a heart cath 4 hours ago, and they came up to you with a femoral approach heart cath site, you need to assess and chart the condition of that site, that insertion site. So is it soft, non-tender, hematoma, bleeding, oozing? Is there calf tenderness, dizziness? Is it the right groin, the brachial, the radial? So you identify the insertion site and what it looks like. And there's a protocol post-procedure for how frequently you do that, and your CTA will go through that with you. From a respiratory point of view, again, this is not a vent screen because not talking about critical care patients, but this is just general med-surg respiratory assessments. So the type of respirations, regular, unlabored, shallow, breathing fast, with difficulty, grunting, etc. What their cough looks like. If you have them on nasal cannula, how many liters? So 2 liters, 3 liters per minute. What their breath sounds, both right upper, right lower, left lower, and right middle. And many patients in the hospital have diminished breath sounds in their lower lobes, and that is considered an abnormality, although it's considered expected for many patients. What type of O2 device they're on, room air, cannula, non-rebreather mask, venti, trach collar. Maybe you're working night shift and they're using their CPAP at night. You can click on that here. If they're on a ventilator, you click on that, and there's a vent screen that we go to in the critical care screens. Are they on an apnea monitor? We don't use those often. We used to use them all the time, but we don't use them often. If you suction the patient, either orally, nasopharyngeally, endotube, trach, if you did trach care, or if you worked with them with incentive spirometry or encouraged cough and deep breathing, we want to take credit for what we do as nurses, so you want to click those. Over here, there is a place, if they have a productive cough, to chart secretions or what kind of secretions you got when you suctioned them. If they did incentive spirometry, what volume they were able to move with that IS. If you are concerned because of sleep apnea and maybe they don't have a CPAP machine, there is a sleep apnea button here that you can click. Now, on any of these categories, no matter if we're in safety and hygiene, neuro, any of these, if I am on this respirations and I right click, I can get a group note. Now I have the ability to type 250 characters to describe respirations. So say in this patient that they were anxious and crying and they had increased respiratory work, I would chart that here, because really it's not really defined over here specifically. So I can tell more detail about the patient and the assessment here in this group note. And when I click OK, it's going to be available to be reviewed. There's a second respiratory button, and this is chest tubes and drains. So here you have where the chest tube is, and you have the ability to chart on 2, and the type of drainage that is in the tube or in the collection device. You can, again, right-click and put a group note, if you want, about a change. So say the patient has a right lateral chest tube when you come on in the morning, and it fluctuates, and it's to water seal. And the doc comes in, and you want to say, well, I changed that. So you're going to say, Dr. So-and-so in, asked to clamp, or chest tube clamped, and patient breathing easily. Click OK. And then the next time you come in, you can go directly to this screen, do a right click and note, and say, patient has easy respirations, no distress, pulse ox 98 with chest tube clamped. Or say they don't tolerate the clamping. So then you can say, increasing respiratory rate, increasing respiratory work, chest tube unclamped, doctor notified. You can do any kind of group note up to 250 characters. Okay, from a gastrointestinal, here you're going to have assessment data about what their abdomen looks like, what their bowel sounds are, if they have a stool, what that character is, if they have symptoms associated to their GI system, so nausea, vomiting, hiccups, tender abdomen, diarrhea, incontinence, etc. If the patient has a fecal management system on a med-surg telefloor, it would only be a rectal pouch. In the critical care areas, they can put indwelling fecal management systems on if they are certified to do so. But we do not use internal collection devices out on the med-surg telefloors. If they have an NG tube, a gastrostomy tube, a PEG tube, that would be a J tube, or if it's an orogastric tube or a T tube for bile drainage, you would click that. And again, you can right-click and talk about it. Put a group note, T-tube clamped, no abdominal pain, or T-tube removed by physician. If you're checking residual and placement, you can chart it there. If the oral gastric tube is to suction, whether it's intermittent, if you clamp it or unclamp it, if there's tube feeds going, if you inserted it or removed it, and other interventions for ostomies are on this side. Now, we don't have a lot of patients with ostomies, so if it's a new ostomy, you will go over with your CTA and with the ostomy wound care nurse about what the frequency of wafer and pouch change and so forth is. But there's the ability to chart it here. So you go from GI then to nutrition. So this is a screen that I don't think was thought out well, because I don't believe there are 5% of patients in the hospital on a regular diet. They mostly are on a special diet. And if you click on special, now you have to say what kind. And it's just ridiculous that there's not a list underneath there. But if you click special, then you have to say, okay, group note, heart healthy, low fat, 2 grams sodium, whatever, right? It was just not thought out well. But if you have a patient on regular, you can click that. If they're MPO, if they need assistance with feeding, if they're tube fed, if they have TPN, if you're supplementing with Boost or Ensure or any of those, if they're on a calorie count. What their appetite is, if they're on a tube feeding, what kind of formula. So this would be your, give me one. I think one of them was Prevere here, one of the brands. So you would type the brand in, you would type the rate, And if you change the bag, which is done every 24 hours, you can take credit for that there. And if they're on a fluid restriction, it goes there. Moving on to GU. This looks at urine appearance and color, how the patient is eliminating. So are they continent, incontinent? Do they have a Foley, a suprapubic, a ureterostomy or a nephrostomy? If they have symptoms of frequency, urgency, so forth. What we did, if we have a patient with ostomy, did we give a care, change the wafer? Did we straight cath the patient? We know we don't like to use indwelling catheters, so did we straight cath the patient, or did we remove the Foley? Over here, this is an area to track how long indwelling catheters are in, and again, that is a quality initiative here, and in all other hospitals, is to reduce the number of CAUTIs. So saying when the Foley was put in and when it was removed gives us the ability to track that. If there is, for a woman, vaginal discharge, or if they're menstruating, you can document that and what their flow is like. Say they had a vaginal hysterectomy, they may have packing in, so you would document that and when it was removed, or the type of drainage with removal. So all of those are GU categories. From a musculoskeletal, now I don't use this a lot on just focused patients, but say you're working on a floor like 8 Tower, which has some ortho, and this is a patient who was a hip fracture, not a hip replacement, and you are working with the patient to get more independent along with physical therapy and occupational therapy. So you want to be able to assess how functional their extremity is. So do they have equal or unequal movement? Is their gait unsteady? Do they require assistive devices such as a walker, a quad cane, crutches, or a wheelchair? Do they have symptoms such as contractures or joint swelling, stiffness, weakness, and if weakness, then where? Right arm, right leg, or left arm. Are they weight bearing? If they're a hip fracture, they may not be weight bearing for a while. So it may be toe touch, and recognizing that that is a limitation for the patient and taking responsibility for helping them. If they have an amputation, where it is, new or old, and you can again right click and say amputation from 4 years ago, stump in good condition, and just click OK. Now here is CPM, and the trick question is, what is CPM? And it is, think about it, continuous passive motion. So we use these devices on people with knee replacements. Now typically, we get patients up and send them home within 24 hours after a uncomplicated knee replacement. But say the patient has to be hospitalized for 3 or 4 days, and they're going to be bedridden because they're in heart failure after their knee replacement. So now you got a patient who has a new prosthesis in their knee, and it needs to move, but they can't get up and move around because they're so short of breath. So the physician may order a CPM put on the patient. Now, we do not, as nurses, take care of devices that we are uncomfortable with. We need to get educated about how to care for these patients. So if you encounter a patient with a CPM and are unfamiliar with it, you would go and find somebody who knows how to take care of the patient with that. So with the CPM, we're going to move the patient's knee in a extension, flexion, and we're going to do it at a certain rate per minute, a certain degree of flexion and extension, and these are ordered by the physician. So again, if you're working with a CTA who is taking care of a patient with a CPM, they will go over that with you. For a patient with a hip fracture and they have it repaired, they may be on an abductor pillow, keeping their legs apart so that their legs don't cross. Or somebody with a hip replacement may be on an abductor pillow. to keep their legs from crossing. We have a C-collar for spine instability. We have lifts that we can identify, a stand-up lift or a total lift. What kind of range of motion exercises we did, if we used ice pack, heat, if they have a knee immobilizer on, a stump compression device for a new amputation, splint cast sling, etc. From a skin point of view, skin is a major issue. It is a quality initiative, and we currently are using the Braden scale. Hang on a sec. As an assessment tool for the patient's risk of skin breakdown. So we can say, okay, they are slightly limited, they're a little drowsy, so they're not totally awake and alert all the time. They have some moist areas between their legs because they have pretty heavy thighs. They only get up to a chair. So they're very limited in mobility. They have not the greatest nutrition, even though they may be obese. And there's a potential problem with friction because they don't move around that well, and we have to sort of turn them with a sheet and so forth. So there's some friction possibilities. So here you get a score of 14 out of 23 on the Braden scale. And it says here a score of 13 to 14 suggests the patient is moderate risk. And so we say, okay, so what do we do? Well, here are the interventions, and certainly there are more than this, but we are looking at turning them every 2 hours. We're using protective barrier to prevent skin breakdown from that moisture. We're going to use a draw sheet. If they are moderate risk, typically, we consult wound care at least for maybe a barrier cream, a special barrier cream, or an overlay to prevent skin breakdown. Here we can document the color and character of the skin and their turgor, which we know in older people is not that indicative of nutrition or hydration. So, moving on, we have 3 buttons for incisions, and we have 2 areas to document incisions on each screen. So you can document 6 incisions. So you think about that, you think, wow, 6 incisions. Well, let's say they had a laparoscopic cholecystectomy and they are in the hospital because they developed some complications. So they'll have the insertion site for the trocar, for the inflator, and for the removal device. Okay, so that's 3 incisions at least, right? Or an open heart. We'll have a mid-sternotomy. We'll have donor sites for the bypass grafts from their legs and chest tube sites. So you could have a patient with 4 or 5 incisions and it not be an uncommon phenomena. So you document the location, what it looks like, if it's well approximated, if it's separated, if it's dry, if the staples or sutures are intact, if the dressing's on or off, blah, blah, blah. If they have a drain in, what type of drain, a JP, a Penrose, if we took it out, or if we compressed the JP, if it's to suction or gravity, if it's a drainage bag, like to a T-tube draining bile to a true closed bag, and what the drainage looks like, and what we did. Again, you could right-click and chart anything else that you need to chart. So you can chart on 6 incisions here. Moving on then to IV assessment. So if the patient has an IV, which this patient doesn't appear to have, you would see it come up. It would say 20 gauge, right brachial, when it was put in, and how many lumens. You would click on that, and then you could say clean, dry, there's edema, infiltration, phlebitis. If it's saline locked, or if you change the fluids, or if you discontinued the fluid and put it to a saline lock, what the phlebitis, if it has phlebitis, what it looks like, or you can just say no symptoms. And if it's infiltrated, again, over here, you can talk about what it looks like, or you can say no symptoms. And if they have 4 IVs, you would highlight it and chart on each one. Now, we talked about incisions, let's talk about wounds. We've got lots of buttons for wounds here. 1, 2, 3, 4, 5, 6. So you can document 6 wounds. So let's think about who that patient is. Well, say the patient was a patient who had syncope at home. Nobody found them for 36 hours and they were laying relatively immobile. They couldn't get up. So they may have wounds on their right ankle, their right knee, their right hip, their right humerus, their right scapular shoulder, and the right side of their head. Those are all different wounds, and they may be of varying degrees of severity, and we may do different things for them. So you would identify the location, measuring it if it is not dressed. We also have the ability to chart tunneling and undermining. Now, a typical nurse on a med-surg telefloor is probably not going to do a huge exploration of a pressure wound with tunneling and undermining. But wound care, the wound care specialist in the hospital, can come in and chart here also. And if it's something that needs to be described more fully, they would chart it on their screen. What type of wound it is it an abrasion? Is it open to air? Is it a skin tear? Knowing older people have very thin skin and can develop skin tears. Blister is a donor site from a graft, gunshot wound, pin site, rash, etc. What does the surrounding skin look like? Is there drainage? Is there a device like a wound vac in the wound itself? Sometimes we use those to promote granulation. Again, inserted and managed by the wound care people, but we make sure that in fact we understand what's in there. And then treatment. Say you don't have a wound vac in, but you washed it with saline and you put transparent film on it, or gauze, or some kind of Curlex. So you have the ability to chart treatments for each of the wounds. Moving on. We have the ability to document when we have critical lab results or radiology results. So say it's a lab and it's a abnormal result, or pardon me, a critical result, not just abnormal. And so we could say, right click, potassium 7.2, sodium 128, hemoglobin 6.8. Click OK, and then what do? You page the physician, and they called back and you got orders, or they didn't give you any orders. Or say the physician, and you can chart the time the physician was notified, and who. But say you waited a half hour, you got a critical lab result, and they didn't call you back. So now you say, I got to call them again, right? So you say, I repage the physician. No response. Now we say, okay, who do you do, or what do you do? Well, we know there's a chain of command in every hospital, and your CTA will help you work up through that to get some physician to respond to you in a timely manner. So you would right click and you would say, physician blah, 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 re-notified, no response, notified department chair or whoever is the next in line to take care of the problem. If you get an order, you can say read back completed, which means I heard it and I repeated it back to verify that in fact the order is correct. Okay, psychosocial. Again, many nurses do not deal with this, maybe once a shift. It depends on if the patient is having an issue, but you could chart cooperative and just go on to the next screen. But many times we use this to try to get a little bit of a description of what's going on with the patient other than cooperative and nice. So maybe they're aggressive or disruptive or combative or refusing care. Or they're depressed. or they have short-term memory loss, especially with patients with dementia. Or they're very anxious because they have an upcoming procedure. They may have delusions or hallucinations, especially if they're going through some kind of DTs or whatever. And if we are concerned at all about their behavior and their fall risks, etc., sometimes we do ask family to be at the bedside. We can use a sitter at the bedside, although they are not common because they are expensive. Sometimes we get prisoners transferred to us from the county jail, and we may have a guard at the bedside. And you, of course, can right-click and talk about any of that. Okay, education. I use this screen almost every time I chart, because every time I interact with a patient or a family, I do some kind of education, and we need to take credit for it. So typically it's the patient, and we talk about, I'm looking for it, plan of care. So I go in and I say, "Hi, Marge. This is Carol again. How you doing? Oh, you're okay. Your pain's getting better. Oh, that's good. Okay, so I'm going to come back and check on you in another hour or so. And if you need anything, you give me a call." That's plan of care, right? Or you can say it's pain management. We always, unless you just sneak in and don't say a word to the patient and sneak out, which sometimes at night that would be what you would do to let him sleep, we frequently have interactions with patients and or families, and we need to take credit for it. Sometimes patients or family ask us questions. We review, they have some knowledge, but we review that knowledge. If you're doing a formal sit down, I'm going to talk to you about your medications and your discharge plan, you talk about those and you take credit for each one of those. We do have 3 buttons here, which are quality initiatives: stroke, MI, and heart failure. And before the patient goes home, nursing needs to make sure that all of these topics are covered. Not every time we interact with the patient, but in total, before the patient's discharged, we need to cover all of these topics and make sure that, in fact, if you look at their evaluation, that they verbalize understanding and return demonstration if need be. Okay? And you notice diabetes is not on here. And that is because it's a huge topic and it needs to be dealt with in a multidisciplinary fashion. So if you are talking about diet, medications, say you click the medication button, you're going to right click and say reviewed need for insulin based on blood sugar after glucometer, reviewed oral diabetic meds, reviewed diet and monitoring of medication doses with exercise, whatever you cover for diabetic education. Falls. Said many patients, most patients in the hospital are fall risk. So we use the Morse fall scale, and we can use the fall risk scale in addition. So do they have a history of falling? Yep, that's why they came in. Do they have secondary diagnosis? Yep, they have dementia. Do they use aids? Nope, they're on bed rest. Do they have IV therapy? Yep. They are very weak and impaired, and they overestimate their abilities, and they are on, diuretics and hypoglycemics, and so their risk is 95 out of 125, which puts them more than 2 meds, and they are at high risk. Okay, so they get put into the fall program. Again, you don't have to chart this every time you go in to assess a patient, but you do it at least once a day. And if something's changed, then you come back to it. There is a pardon me, here's one of the mandatory ones. Pardon me. 95. There we go. There's a secondary fall documentation button. So what do if they're low risk, moderate risk, or high risk? So call lights within reach, bed in low position, brakes on, blah, blah, blah. If they're moderate risk, they get the yellow slippers. Sometimes they have personal alarms or bed alarms put on in order to keep them as safe as possible. Moving on, we do not use physical restraints on patients on a med-surg telefloor. Rarely do we, and it's only in extreme circumstances. But we do use bed alarms and personal alarms. So justification of why you're doing it, so patients confused or disoriented, or their safety risk, or their safety risk. They may be on a bed alarm or a personal alarm. And we need to document it so that, in fact, we can show that we are aware and that we are using it judiciously. So if the patient gets better and they're not confused anymore, and so their safety risk goes down to low, you may take the personal alarm off and leave the bed alarm, or vice versa. If the patient were to have soft or hard restraints, again, we don't use those outside of critical care, except for rarely, we would have to document then when it was put on, when we got the physician order, who and how we educated the patient and or family, and then we have to check their neurovascular condition, their vital signs, offer them toileting, etc. So there's 4 buttons for documentation of what we do when patients are in restraints. So we have pretty much covered the med-surg tele buttons, but I want to talk about miscellaneous. So remember, you could right-click on any category and get a group note. Well, miscellaneous gives a group note. So you right-click on that, and now you've got the ability to document just with prose. And because I'm an old nurse and I'm used to paper charting, I usually put a summary note at the end of my shift on every patient. So I've taken care of the patient for 12 hours, and they were very confused and short of breath when the shift started, but through some diuresis and increasing their O2 and some orientation, they're much better. I want to chart that. I want to paint a picture without going to buttons. So I would just type that in, knowing you can only put 250 characters in this screen. So I may use all 3 screens to chart what I want to chart. If you click on NA stroke scale or sepsis screen, it will not let you out until you complete the entire screen, period. So if you're going to do it, do it. Use it as a tool to document your assessment, but just know once you go in, you're committed to completing the entire thing. So I will show you the NIH stroke scale screen real quick. So level of consciousness, click on the little plus side, the patient's arousable by minor stimuli. Close it. Click on, Click on orientation or level of consciousness. They answer both questions. Do they follow commands? Yep. Best gaze, they have no problem with deviation of their eyes, so that's normal. Visual, they have no visual loss in their visual fields. They have no facial palsy, but they have a little bit of drift in their left arm and in their left leg, but their right arm has no drift and their right leg has no drift. They have no limb ataxia, which is a cerebellar evaluation. They have no numbness. They are able to identify all the pictures in all the pieces of the pictures, so they have no aphasia and no dysarthria, and they have no problems with inattention or what we used to call neglect. So I completed them all. The patient gets a score of 3 out of 42, and now it will let me go out of the screen. If your patient is a stroke patient, we would do this frequently in the ICU. As the patient moves up to the stroke units, 10 or 8, we may do this once a shift. And then as the patient gets ready to go to rehab and so forth, they stop doing the NIH stroke scale unless there is a worsening of condition. Okay, so say you got your charting all done and you're feeling pretty good about it. And so now you say, okay, CTA, I need you to co-sign it. So they're going to pull up the co-sign button. They're going to say they reviewed it and who they are signing for and what time frame, all shift, half a shift, this event, whatever. And then they would co-sign it using that button. Okay, I want to go through CWA real quick. So, patients, an unidentified alcohol user, and they come in for routine surgery. And so they have the surgery and they get on a mid-surg telefloor, and now they are showing signs of DTs, and before the patient can be sent down to critical care, or if they're on step down, you're going to actually do the CWA scale with Ativan dosing on that unit. So now you'd have to be able to identify what their CWA scale is, and it will tell, based on protocol, what then amount of Ativan needs to be given, because Ativan is the drug of choice for patients going through alcohol withdrawal. So say they have some nausea. You can feel some tremors, but they aren't visible. They're mildly anxious. They're not really agitated, but they do have beads of sweat. They're disoriented by more than 2 days. They're really not complaining of an itch. They haven't got any hallucinations, and they're not seeing things yet. However, they had a pretty good headache, and so now you have a score of 12. So that, you go then to the CWA protocol, which gives you physician orders for the dosing of Ativan. And then we give the dose, and we go back, and we do another CWA scale, and we give different doses of Ativan as the patient goes into DTs or out of DTs. So now you need to think, okay, what's the major risk factor of dosing a lot of Ativan? Because we could give a lot of it. So the answer is, ta-da, respiratory depression. So if this patient is getting more and more doses of Ativan for alcohol withdrawal, then this patient needs to be in a more closely monitored unit and most likely would go down to a critical care unit because they may end up intubated. Okay, 3 other screens. Here's a swallow screen for you. If the patient is a post-stroke, it's a good way of charting your evaluation and assessment of their swallow. Speech therapy uses this also, so be aware that you can go back in and review what their assessment is. Here's an event button. So say you needed to call a rapid response code, and you want to chart about why you did that. So the location was, the patient was in the chair, they had acute change in condition, and what the patient didn't